So now we'll move on to another inflammatory disease, and we'll hear about some plasma, lipids, metabolomics, and how this may relate to the gut microbiome in common variable immune deficiency. So Silje Joergensen from Rikshospitalet, please.
Thank you. I work as a consultant at the section of clinical immunology and infectious diseases at Rikshospitalet, and I'm also a postdoc at the Institute of Internal Medicine. So the disease I study, most of you haven't heard about, but it's still the most common clinical relevant primary immune deficiency in adults. And it's characterized by a B-cell defect, and all the patients have reduced IgG. And to get the diagnosis, you also need to have a reduced IgA or IgM or both. It's a very heterogeneous disease. Almost all the patients have infections in the upper and lower respiratory tract, but also 70–80% of the patients have inflammation and autoimmunity. And that can affect both the gut or the lungs, or you can get thrombocytopenia. So this disease is an interesting disease model because you have both immunodeficiency and inflammation. Previously, we have shown that CVID patients have altered gut microbial profile. They had reduced alpha diversity, almost at the level of IBD, which was not related to antibiotic use. And we also seen altered lipid profile in these patients with reduced HDL and also altered cholesterol efflux. And this is particularly in a patient with autoimmunity inflammation. But it's important to emphasize that these patients do not have increased atherosclerosis risk. On the background of these two projects, we have hypothesized that there is an altered fatty acid profile in CVID patient, which we think might be related to gut microbial dysbiosis. So in this project, we measured plasma fatty acids in 39 CVID patients and in 30 healthy controls. And also in the CVID patient, we collected stool samples and did 16S profiling. We had a very detailed food frequency questionnaire, which was a recall over the past year. And we also reanalyzed fatty acid in a randomized controlled trial where we used the antibiotics rifaximin. And this is, I'm not a dietitian, but this is a simplified illustration of the metabolism and biosynthesis of N3 and N6 PUFAs, which many of you know as omega-3 and omega-6. In relation to diet and gut microbiota. And on the left side here is the diet source, with, for example, oily fish and different oils. And the blue here are the essential fatty acids, which are only obtained by diet. And the yellow greenish circles here are the non-essential fatty acids. And they are mainly synthesized in the liver, but is in limited amounts. And here we have in this illustration highlighted where we think the microbiota might play a role. So this is the first slide of the results. The patients were matched in terms of age, sex, and BMI. And we found reduced proportion of two of the main N3 PUFAs, omega-3, EPA and DHA in CVID compared to controls. And these have anti-inflammatory properties. And there was a tendency, but not significant, reduction in N3 PUFAs compared to controls. And this is one of the reviewer questions, where we then looked at, remember from the beginning, I told you that the CVID patients have reduced serum IgG. And we supplement them, we give them subcutaneous or intravenous IgG. And we found that there was a correlation, significant correlation with many of these favorable fatty acids, which is very interesting because this is at the core of the disease of CVID, and it's a correctable immunological feature. We can give more IgG if this is if it's needed. And when we had this result, we went to the literature and we found a recent animal study where we found that the appropriate absorption of the dietary EPA and DHA, which is the omega-3, from the gut were dependent on the presence of plasma IgG, which we thought was an interesting link between one of the major immunological features of CVID, reduced IgG, gut absorption, and gut microbiota. And this was not the same for N6-PUFA or MUFA. Then we looked at the N6 PUFAs, or the omega-6, which was significantly reduced in CVID compared to controls. And this was mainly due to the reduction in LA, which is linoleic acid, which is the major contributor to N6 PUFAs. And in recent studies, it's been shown that some of these subgroups of N6 PUFAs have anti-inflammatory effects, particularly LA. For the MUFAs, there was also an increase in CVID, but it's, as far as I know, not established if increased or decreased MUFA is associated with the benefit to health or not. Then there is also some indexes which are commonly used. An anti-inflammatory index was the proportion of the potential anti-inflammatory fatty acid relative to the potential inflammatory fatty acid, which was reduced in CVID. And similar with the omega-3 index, this was also reduced in CVID. So from this, we can conclude that CVID patients have a potentially unfavorable composition with a net inflammatory effect. And then some of you think that this might be due to diet. If there was a huge difference in fish or oil intake, this might explain the results. But for the food groups, or even when we split the nutrients into PUFAs, there was no significant difference between dietary intake between CVID patients and controls. We also did, and they do this in some of the fatty acids studies, correlation with the reported EPA and DHA, which is the omega-3, and what we actually measured in plasma. And we found a strong correlation between the reported EPA and DHA and what we measured in plasma. However, for plasma LA, which you remember is one of the essential, most important N6 PUFAs, there was no significant correlation. We then looked at compared the stool samples, where we looked at the alpha diversity and correlated them with the M3 PUFAs and N6 PUFAs. And here we showed a strong correlation with N6 PUFAs and alpha diversity. And this was even more so for LA, which is linoleic acid, which we have shown is decreased in CVID, which was not correlated with the dietary intake. And furthermore, we looked at the 15 specific taxa that we previously have shown is different between CVID and healthy, but we didn't get, apart from the sulfovibronasia, which we know is decreased in CVID and correlated negative with some of the omega-3, we didn't find any significant correlation. In 2018, we published a study, randomized control study where we used rifaximin for 2 weeks, and then we had a 6-week observation period. And then we showed that the alpha diversity was reduced with rifaximin, but after 6 weeks, they went back to the normal level. And this is an important proof of concept because rifaximin is just negligibly absorbed into the systemic. So if you get any changes in the blood, it's probably due to the alteration of the gut microbiota. We also identified 16 bacterial taxa that were significantly changed by rifaximin. And when we looked at the effect of rifaximin on N6 PUFAs and N3 PUFAs and MUFAs, we found that the group of patients that received rifaximin actually had a decrease in N6 PUFAS, and this was sustained even 6 weeks after 6 weeks observation. And this was also true for LA, the main N6 PUFA. In contrast, we saw that for MUFAS, the patient receiving rifaximin actually had an increase, but the change was not sustainable after 6 weeks observation. And then we looked at the 16 taxa that were significantly changed by rifaximin and correlated them with the significantly changed fatty acid. And we found 2 taxa in the Firmicutes group that strongly correlated with the N6 PUFA and LA. So to conclude, COID patients have a potentially unfavorable fatty acid profile with reduced EPA and DHA and a reduced anti-inflammatory index. Serum IgG levels were positively associated with plasma N3 PUFAS. And interestingly, N6 PUFAS and LA were decreased in COID patients and were positively associated with gut microbial alpha diversity in stool samples. We also shown a 2-week course of oral rifaximin led to a reduction of N6 PUFAS. And the altered plasma fatty acid proportion of N3 and N6 PUFAS did not seem to be related to altered dietary intake. And this paper was published 2-3 weeks ago in the Journal of Clinical Immunology. So if you want to read any details, it's online. And I want to acknowledge all the co-authors, particularly Tonje, who can be here today, who is the first author of this paper. Thank you.
So, thank you very much, Silje, for a very nice presentation, lots of data. Are there any questions from the audience? Somebody approaching the last chances of saying anything on the microphone today. There are many things you could ask around this, but is there any other evidence suggesting that antibiotics influence fatty acid lipids levels in the blood in general? Or is this something completely new?
I think many of the fatty acid studies are done on different diets, and not that many is done where you combine both diet, plasma, and an antibiotic intervention. So I think that's quite new. And also have details like microbiota data. So I don't know exactly, but we didn't come across any similar studies.
No. Do you think, well, Fredrik?
Fredrik again. Might be, and thanks for a nice talk. Might be a bit strange question, but why did you choose rifaximin? Was there a particular reason why you chose that antibiotic?
Yeah, that's a good question. When we did that intervention, we considered other antibiotics like Citromax, for example, but this is a very good drug to use as a proof of concept because it has negligible absorption in the blood. So it just acts in the gut. So the initial study was to look at inflammatory markers. It was a complete negative study. So actually this is the first time we found something that actually rifaximin had effect on, apart from the gut microbiota. But then it's as a proof of concept, because we chose this drug that is not absorbed systemically, we can say that it's probably due to the changes in the gut microbiota that these changes in the blood occur. So this was very specifically selected intervention.
So do you think these fatty acids changes somehow influence the disease or disease phenotype in CVID, or is it some epiphenomenon?
I think this is just we've done some studies around metabolomics, lipids, and I think this is just one piece of the puzzle that fits into some of the other research and planned research that we're going to do. But I thought it was quite interesting that we could see that there was such a strong correlation with IgG, because it was some of the patients had IgG at 2, and some at 15, and normal is just about 7, above 7. So not only for CVID, but in general, that maybe if we increase the IgG level or more aggressive in therapy, maybe this could have effect on the fatty acid profile and be beneficial to the patient. Maybe.
Okay. Very good. Any other questions now? If not, thank you, Silje. Thank you for coming here.